Welcome to Her Body and Mind podcast. My name is Dr. Ciara Fox, and this is
Amanda Sarich,
a registered clinical counselor. And today we are going to be talking about Ozempic, also known as, or the category of drugs known as semaglutides, and then also the category of drugs, tirzepatide. So I did a social media post last week on why I, as a naturopathic doctor, utilize these particular drugs in my practice, because there's a lot of controversy around this. So I did a post, and a lot of people were either interested in what I had to say or just quite validated and excited that someone was actually publicly saying the things that I was saying. So I thought, well, why not talk about it on a podcast and talk about it in a little bit more of an extended format. So here we are.
Yeah, and I said, I don't know anything about any of this, so we're all going to learn together, and that's going to be nice.
Very good. So I'll start off by just giving some reference as to, for those of you who don't really understand, or there's a lot of language and terminology around these things. So we're talking about primarily injectable peptides that are used to manage diabetes, so type 2 diabetes, and sometimes also used in type 1 diabetes, as well as just for weight management. So very popularized in the last three years would be Ozempic. So that was kind of the first thing that hit the market. So Ozempic is semaglutide. So it's a GLP-1. And so originally used for type 2 diabetes. And then the Kardashian sisters came out very publicly started using Ozempic to manage weight. Not that any of them were overweight or necessarily needed it per se, but I think that that's how we kind of came to know it and start to use it in alternative ways outside of type 2 diabetes. So they kind of popularized it. So it was in pop culture, and then a lot of people obviously became interested about it. So here we are now with a lot of kickback. So there's been a few years since then, and there's just a lot of controversy over who should or shouldn't be using this drug. And so going back to the Kardashians, the perception was why would they be using them? They don't have diabetes. Look at their bodies. They're perfect, etc. So that's where the controversy lies with these things. And so when I'm utilizing it in my practice, or even my patients are scared to even bring it up, because now there's a lot of shame surrounding who should or shouldn't be able to use them. Because from the outside looking in, if you don't look like you're overweight, if you don't have type 2 diabetes, people think there's no reason to be using them, if that makes sense.
Hey, I've already learned a lot. I didn't know this was popularized by the Kardashians.
You didn't?
Nah.
Okay.
Look at us.
There you go. Okay. So that's honestly that's, I think, how it publicly kind of gained its most momentum.
Interesting.
Yeah, totally. So Ozempic, and then with that, so Ozempic is used and is approved by the FDA for type 2 diabetes, versus Wegovy, which is the other semaglutide that we use, is approved for weight loss. So same drug. So they do the same thing, but they're approved for two different health concerns. Versus tirzepatides, which now this is kind of the latest and I would say quote unquote greatest, which is a combination of GLP-1. So it's got the semaglutide in it, but it also has a GIP in it. So the two drugs that we're looking at for those are Zepbound and Mounjaro. So Mounjaro is used in type 2 diabetes, and Zepbound is used for weight loss, obesity. So again, approved for different things. But they mechanistically, as far as a drug category, work essentially very similarly.
Okay.
Does that make sense to you?
It does.
From someone who doesn't really...
Yeah, I've heard lots of those names before.
Yeah.
So Ozempic, I have a lot of clients that are on a lot of these medications.
Yep.
I hear the shame piece around it, especially when they don't feel like they should be, or they'll say it to me well, yeah, I'm on this. And then, so yeah, definitely the shame piece. So interested to hear more about that for sure.
I actually want to hear from you about that. So when they're saying the shame piece, is that something that you help them
Well, with? I know enough about this from you in terms of this language. Don't know a lot about I was what's a GLP-1? You're what? So
that's my bubble.
Yeah. So I know enough that I've had a lot of clients that are your patients that wouldn't necessarily maybe objectively look like they should be on a weight loss medication. But there's a lot of reasons blood sugar maintenance and all of those things that it's really benefited them from.
Yeah.
And so I think there's not really space for shame for probably anything.
No.
If you're using it, then there's probably a reason. And I think like, look at like so many of the other things we do. Like my face is full of Botox. Like, I mean, who gets to decide what you should or shouldn't do, right? Like, so I, from a counseling perspective, work to like pull apart that shame to just like decrease it, no matter what the medical or non-medical reason is. Yeah. Shame's never helpful.
No, it's not.
Yeah.
So like getting into like, I'm a naturopathic doctor. So when people think of me, they think of like crunchy granola, someone
wavy skirts.
Like, yeah, maybe like
with some dreadlocks.
Dances around a fire at night. I don't even know.
Lots of crystals. I mean, we do like crystals, but that's the main thing. Just waving them around.
Some people think of witches, which I may or may not have been in my past life. But naturopathic doctors really like our medicine is rooted in things that are more holistic, more natural, have little to no side effects that really stimulate the body's natural ability to heal itself. That's like us in the smallest nutshell there is possible. But at the core is like, first do no harm. Obviously, we don't want to do harm to people. We want to act preventatively in medicine. So prevent disease progression or prevent disease from actually happening. And I think that's where like these drugs can be very helpful, because although it's nice to say like, why don't you just work out and eat less? Because that's usually what happens when someone goes to their GP or their MD, is that is the advice that's provided. But the reality is that we know better. We know better than calories in versus calories out. Now there's a lot of genetics that are involved in why somebody's metabolic rate or their sensitivity to glucose and carbohydrates is different to this person sitting next to them. And that's where I come in my office and help educate people about, why they're struggling on a variety of different levels with whether it be their weight or their blood sugar, their hunger, etc. So yeah, there's a lot of reasons these drugs can be a preventative tool to prevent diabetes from actually being full on, to prevent cancer, to prevent non-alcoholic fatty liver disease, to prevent a heart attack, a stroke. Like that's the power of these drugs. And some people, even if they eat the right things and move, their actual labs that we're testing or even their body composition and their visceral fat will not budge. Yeah. And these are the things that we need to consider when like, well, at what time do we start to use this intervention? That could be an example of that. Or there's someone who's struggling with mental health, who is anxious, depressed, but they really are struggling with their weight and their metabolic health. And they have all these risk factors that we know if they continue to go on the path that they're on, that they will end up having a heart attack or developing diabetes. And so we have to find somewhere to start breaking the cycle for them. And sometimes exercise and eating a balanced diet isn't the place to start.
Well, and for a lot of people, it's just not possible. Like if we look at like clinical depression, the fatigue and the heaviness in your body and just like this like significance of your low mood, like going out for a walk is it's not possible. Even a walk, let alone like getting your heart rate up and like lifting weights and running. I mean, a shower is hard. So what do you do?
Totally. I call it like in my practice, there's always this like classic triad that walks in. It's someone who wants to lose weight, has really low energy, and they might be like anxious and depressed. Yeah. So all three. It's like terrible. This is like really common as far as like people saying these are my primary health concerns. And they just feel stuck because they're in this loop, and it's always about like, how do we break it? And I always say to people is like, we first have to figure out why your energy is low. And that could be for a variety of reasons, which we have other podcast episodes on. So we have to figure out why your energy is low, work on that first, because that then transfers into better moods, more motivation, etc. And the mental health part piece. So those are actually the first things to go, because you're going to be hard pressed to go for a walk or exercise or eat the food if you have low energy and your moods aren't right. So again, these drugs, if we can kind of break the cycle, start that in the process, because we know they're high risk already. Like they're on their way to something, right? Or maybe they're just so severely insecure and self-conscious that like they need that to help with their mental health. Like there's so many different reasons for
in comparison here, right? So we're always like, what you spoke about like a few minutes ago was that like there's things internally that are making weight loss harder.
Yes.
But if we don't know those things, by like actually kind of like taking a look beneath the hood,
Totally.
we're just calling ourselves like not good enough, or we're not trying hard enough. But there's lots of people, and I know this from you, is like you can be trying all you want, and if you're just genetically not going to be hardwired the same as the person beside you,
you got it.
Ugh.
Yeah.
And then that's going to impact shame and mental health and self-worth and all of the things.
100%. And like I can tell like just from asking the questions about someone's family history. So like, do you have cardiovascular disease? Is there someone that has diabetes, cancer, autoimmune? Like you ask all this family history stuff, and you can usually see a pattern, whether it's like a lot of people have autoimmune, or a lot of people have type 2 diabetes, or people just don't know their family history or think they know their family history. So even if you don't think there's diabetes or autoimmune, I would still like question people, because sometimes they just don't want to say it.
Yeah, that's fair.
So a lot of people come to me, like they're like, no family history, and then they like text their mom while we're sitting there, and they're like, oh,
turns out
actually grandma and mom have hypothyroid. I'm like, yes they do, and probably so do you. Anyways, I digress.
Well, there's so much shame in all of these things, especially if it's anything, and it shouldn't be, because we, in a perfect world, love ourselves at any size, any body composition, but there is, and we talked about this in other episodes, like the shame and the like pressure, especially for women.
Yep.
It's complicated,
and we don't always get to choose how our body likes to distribute fat or react to the food that we're eating. Like there's such hardwired genes when it comes to type 2 diabetes in particular. There's this huge misconception that if you develop type 2 diabetes, it's because of your lack of exercise and your diet, which are contributing factors. But the reality is that generally speaking, there's diabetes in the family, which makes you more susceptible to developing it, even if you're eating pretty healthy. Or let's say me and Amanda, like, okay, I don't think you have a family history of diabetes, do you?
No.
Not
that I know of.
Right? I do. Everybody on my dad's side of the family, I think they're all diabetic.
Huh.
Everybody. Like his sisters, him, my grandpa for sure. And so it's just like really deep there, and there's genetics there. So me and Amanda could exercise the same amount. We could eat the identical diet. And obviously, like, let's say our sleep's the same and our stress is the same, all the other things are the same. I would still react differently to carbs and sugar than she would because of my genetic predisposition. So there is something there to be said where there's a little bit less leeway when you have these genes. And that's where it becomes frustrating with people who have those genes, because they see Amanda sitting next to them being like, well, why can she get away with that and I can't? It's a real thing. So
important for shame, because there's just this internalized, like the narrative that you're just like lazy, and people think this about themselves. They tell me this about themselves. I'm very excited about that. It's just, and then that's going to make you more fatigued and less likely to move, because you've decided that you're like not good and lazy, and then the cycle continues.
And then there's the scenario where like literally that the person is doing all the things and they always have. They're like, they come to me, they're like, well, maybe if I just like also cut this out and did that. And I'm like, more restriction, creating more like of an unhealthy relationship with food and what it is for you. Like, it's just such a slippery slope. And like, at what point do we say like, you know what, we just need to listen to what your body is telling us and give it the support that it needs. And like, I hate to break it to everybody, but there's a lot of like supplement companies that'll say like, this is the natural Ozempic. Right. There's no natural supplement on the planet that works like a GIP or a GLP. So let's be clear.
This is from a naturopathic doctor. So double, like, people feel like if they heard that from like a GP, they'd be like, oh, but this is from someone who does know natural supplements. And you're saying like, it don't exist.
It's not that they don't help with insulin resistance and glucose stability and even hunger, but you can't go on it for 16 weeks and get this drastic amount of weight loss from it. Like, it can help correct metabolic imbalance and, reversal of non-alcoholic fatty liver over time, but it's not going to work like this. They're not the same. One is like working very quickly. The other are hopefully long-term going to help correct, but they're not the same, and they will never act this way. And that's like, the very defining part of that. So though I use things like berberine and NAC and inositol and chromium, all these lovely things for glucose and insulin, but it's not the same as this drug.
Well,
so
I
we
think,
just need to be clear about that.
Well, it's like so many things, like weight loss, mental health. There's like a lot of people, I think manipulate's the right word, where it's just like, this is the fix and this is the thing and buy this supplement or go on this program. And it's just.
And when you're desperate, you
yeah.
pay the hundreds of dollars a month. And I'm like, to people, I'm like, yeah, like, I'm sorry about that you spent all that, but now we're going to focus on the things that like you might need to take some supplements, but like take the things that you actually need that we know that will work versus these like pyramid scheme, blah, 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 whatever they are. Yeah. I don't even know.
And what about like the sigh of relief that like, oh, okay, I don't have to spend hundreds and hundreds of dollars and like literally like kill myself to achieve this thing that feels impossible.
Yeah, totally. Now, another piece of this that I want to touch on, it's like when it comes to, well, what are we looking at? Because there are some like old school ways of determining, you know, whether your body, just from a physical appearance, is like in a healthy state, which isn't always an indicator. And classically, we use something called BMI, body mass index, which you've probably heard of.
Yep.
Do you know anything about that? Good, bad, neutral?
No.
Nothing. Okay. Yeah, BMI. So it's basically your weight divided by your height. And then it spits out a number, and then you're put into a category and told like, well, you're in a healthy BMI, but that doesn't consider actually the more important factor, which is waist circumference. So when it comes to metabolic dysfunction, insulin resistance, risk of cardiovascular disease, cancer, it's actually visceral fat storage. So we think of someone who, you know, has, you know, skinnier limbs, but has like more abdominal obesity. That's the bigger risk factor than someone, let's say, is, you know, carries more weight in their lower body, but has a thinner waist. Like we know that this population with more visceral fat, which is where the waist circumference comes in, is very helpful. So we now actually use waist circumference divided by your height as a more accurate measure for your risk without even doing blood work. You could do this yourself to see like, what is my risk based off of waist circumference divided by my height. And you'll get that number, and where we want to be, like the happy place for that, where we know it's good. It's not like too little, too big, would be between 0.4 and 0.49 is like the number that we're looking for there when it comes to talking about, this is just risk of disease. So we're not talking about like someone who wants to lose weight, even though there might be low risk just because, you know, they feel like insecure in their body and they want to, which is okay.
Yeah.
But this is just talking about like metabolic health and longevity and how we want to live our years out, healthy versus unhealthy.
Oh, I'm already learning so many things.
Yeah. So that's waist circumference. And then, yeah, as far as like the visceral fat, the reason why it's such an issue, because it does create more inflammation, more insulin resistance, and which then causes dysregulated lipids, so higher cholesterol, more sticky cholesterol, let's call it, just for like layman's terms, and inflammation then leads to also increased risk of cancer. So those who have, you know, more visceral fat are more likely to die of all causes of mortality than someone who is in that healthy range. And that's just very basic. I think it's like you're increased by 60% of dying of all causes of death.
And if you're listening to this and feeling shame now, notice that in your mind and challenge it. Because as soon as we start talking about weight, I have so many female clients. I can just hear these risk factors, which are really important to know because knowledge is power.
That's the point.
But I can just see so many people I know just like beating themselves up already. And so it's like, if that's happening for you at this point in this episode, please stop, because there's so many factors that contribute to this.
Which we touched on.
100%. But just notice that and just take a quick reset and just tell yourself you're wonderful and beautiful and enough. And then we'll continue. Just a little side
I think
note.
the bigger point is that there's things that we can do that are within your control that can be, I would say, like, and this where it goes, kind of my bigger point about this is with these drugs, it's, okay, what is the risk? Because people talk about risk with these drugs. That's the big thing. It's like, what is the risk of you as a person taking this drug? What are the likely side effects, whether that's acute or later side effects down the road versus what are the risks of you not taking the drug. And that's what's most important to know about these is we do want to be like informed about what the risks are, right? And I think the big bad scary that have been reported are biliary or gallbladder issues, pancreatitis. In rat studies, they found thyroid cancer to develop, which this isn't in human studies. More acutely, gastroparesis, which is actually, we know that you can get constipated on these drugs, but gastroparesis is like complete shutdown of the gastrointestinal tract, which is scary for sure. And then you're more like, I don't want to say minor, but the reason why people normally actually don't or aren't able to sustain the use would be things like nausea, vomiting, chronic diarrhea, constipation. Some people do experience mood changes, so lower moods. So these are very real things for people that they experience. So risks, there are for sure risks being on these things. And then I've also then mentioned, well, what are the risks if we stay in the cycles that we're in long term? And arguably those things, not even arguably, this is a fact, are way more likely to happen to you than the long-term risks of being on the drugs. Way more likely to happen.
I just love that language. I use it a lot when people are, not that I prescribe medication, but when people have been encouraged by their naturopath or medical doctor to go on a medication, but they're very much like, I don't want to. And I use that too. Like, okay, so they've said there's these risks, but it's so important to look at the risks of not taking it because it's not often framed that way. And then it feels like we're only looking at one side of it if we're just looking at the risks of taking it. So good.
Yeah. So that's like the biggest piece. So if you're out there, like you've been thinking about it, but then you're in the shame cycle, but then you're stuck and you're like, all the things. The point of this is to know that there's strategies and that like truly that's what it comes down to is like, what's the consequence on either side? Where do you fit into that? And then what do you feel like makes most sense for you personally and not like your friend or your mom or the people on social media who like, I mean, there's naturopathic doctors that are really bashing GLP-1s, GIPs. And another kind of risk that we didn't talk about was bone density and muscle mass, which are huge. And so another reason why I want to talk about this too is that though, yes, those are a risk, but they're just risks that actually can be mitigated if we can teach people what to do while they're on them. So the bone density loss is really from not having enough stress on the bones when you're using it. And so you will get breakdown. If you do or are able to do weight-bearing exercises or upper, lower body, whether it's body weight to start, being very gentle with yourself, especially if there's mental health or lower energy things, but there's ways to protect your bones in a way and muscle for that matter. So not losing too much muscle tissue while you're taking them because you can muscle waste if you don't do weight bearing exercise and if you don't eat enough protein. And if you're being mismanaged on the drug, someone might, I would call it overdose you where they're giving you too much. So your appetite is so suppressed that you have no hunger signal and you just don't eat really anything. And that's another thing with not getting proper monitoring and proper coaching while using them because it can very easily go in that direction. So you have to work with a care provider that cares about these things and will in a way find a way to enforce and support you with where you're at in your life and still make it manageable. So there's a lot of strategy. It's not just like, I know some patients have walked into their medical doctor's office and then they actually will prescribe. It's like, okay, here's the drug, okay, see you later, bye. And then that's it.
Yeah.
Like, but then what?
Yeah.
And so there are consequences. Like you don't want to be developing fractures. That's a death sentence. You don't want to be muscle wasting. That too, like reduces your resilience for being able to come off the drug because your muscle tissue is the most metabolically active tissue in your body. So if you lose 40% of your muscle tissue, want to come off this drug, but now your resting metabolic rate, which is basically how many calories you can burn in a day, is way lower. You're going to eat regularly, but still your weight's going to shoot up really fast. You need to preserve the muscle tissue.
Oh, that's so interesting. Yeah.
Does that make sense to you?
Yes.
Does it?
Yeah.
Okay, very good.
Wow.
Yeah, so there's a lot to it. It's although it's like a tool that can be used and it's easy to use, but there's a lot of nuance in it and there's ways that we can use it in lower doses that can be actually quite successful.
When I think something I hear enough is that people are going on this medication and not making any like lifestyle changes. So it's going on the med, expecting it to do all of the heavy lifting when we're not changing like how we're eating or living at all. And sometimes it's not going to be possible right at the start, like you're saying.
Yeah.
Can you speak to a little bit of that? Like how important is that to like also be switching like binge eating or emotionally coping with food in the evening while on these medications? How much?
Well, it usually shuts that down, to be honest. Most people who struggle with binge eating or emotional eating, it's the food noise that they kind of help in the central nervous system. That's part of the mechanism, is that it actually really helps with those things. So those things are way less.
Yeah.
That's generally how it works.
Okay.
So I would say you can't say 100% of the time, but most of my patients who a big part of their picture is the food noise, they're like, that is the biggest thing that they do notice. And when it starts to come back, let's say we start on the lowest dose, they're like, I can kind of see that creeping in, then we'll consider going up. But very rarely do we need to get up to the higher ends of the doses to get results. Sometimes, but honestly, like it's in my practice anyways, not as common.
So it just naturally is changing.
Right. And then there's the other scenario where people use them and they don't notice a huge body composition shift or weight loss. And that's where we do need to be patient with the body, because sometimes before we will get more of the superficial kind of subdermal fat tissue stores kind of weight loss. First, what will happen is we need to reverse things like the non-alcoholic fatty liver disease, which is fat tissue within the liver, because that needs to kind of process first so the liver can be like functioning better, because the liver does regulate how your lipids are broken down or stored, your insulin sensitivity, your glucose storages. So it does a lot. So the body has a lot of, I want to say like reversal. There's a lot of reversal that has to happen before some people can start to see results on these. And not only that, like people that might feel like metabolic or physically they're not changing, but if we run their labs 3 months later, although they haven't dropped crazy weight like other people, we can see that their hemoglobin A1C is better, their insulin's better, their fasting glucose is better, their liver enzymes are dropping. You know, we can see metabolic shifts, but they're not getting the same like quick results as maybe everybody else. And that's okay. But again, you have to work with someone who can coach you through this, because then it's like, why me? And it doesn't work. And there's no other options. And, you know, there's a lot of stories that go along with that. But sometimes we even need to be patient while on drugs that seemingly are like quick acting. It's not always that easy.
And it speaks to the variance in human beings, the variance in how our bodies are created that we have absolutely no control over.
You got it. Yeah. So I think like that's kind of the bigger pieces that I wanted to touch on with this particular topic. Any questions about that or comments?
No, I think you explained it well. And I think the biggest thing I hear, well, probably because of the lens I see the world through, but it's just like there's things that you can do that you don't have to feel stuck, and that your body, if it's so hard to lose weight and that's what your goal is, which it doesn't have to be your goal, but if it is your goal, then there's things you can do, which is really great.
Totally.
I think something I hear actually about this is tricky. If you don't have good benefits, these are expensive. And so that is a barrier for people, which is unfortunate. There's a number of people that wouldn't be able to access this, which our world is a complicated place. But
yeah, and I don't want to get into too much detail about how we can prescribe the different forms and brands of these drugs, but there is like off the jump ways to dose Ozempic, particularly where we can use larger pens but at lower doses, so the pen actually lasts longer. So if using semaglutide is effective for someone in that way and we can stay on lower doses, it becomes more economic than otherwise, though the other drugs, they don't work that way. The pens, you can't click count. So click counting is something that I use all the time with Ozempic to keep the drug cheap, because if you're not diabetic, it's not covered. And same with Wegovy, it's not covered Mounjaro is not covered. Versus the weight loss drugs, they're really never covered. I don't think I've ever seen anyone get drug coverage for those. But if you can prove you're diabetic, then you can get coverage through your extended healthcare plan. But then as soon as you're not in the diabetic range, which is still metabolically unhealthy and unsafe, because there's a huge range, but as soon as you're below what LifeLabs flags you at, then they're like, hey, you don't get coverage anymore, but you're still high risk anyways. It's a terrible system. One day there'll be cheaper versions. I think that Canada just got like a non-name brand semaglutide approved recently that hopefully is cheaper. So we'll see what happens with that.
Okay.
Yeah.
But again, speaks to if you are working with a practitioner that knows the things, it's just having those conversations about maybe other ways to prescribe it. Yeah.
Totally.
Yeah. I think I learned a lot.
That's good.
Thank you.
Now you know the things.
Okay. Well, if you have any questions for mostly Dr. Fox, because I was just along for this ride, drop your comments or questions below. She will answer them. If you're like, oh, I want to know more about this specific part of this, also put that below. We will be happy to do that. Like, share, follow, all those good things. And thanks for being here.
We'll see you next episode.
Bye. Please contact your own healthcare providers before you make any changes to your health and wellness protocols related to your body and mind.